implementation strategies for population health and financial gain too. As you might have heard Deborah saying before, we'd like you all, if you're not speaking, to mute your lines while the presenters are speaking so that there's not any background noises or interruptions. And before I turn the program over to our presenters, I'd like to explain a little bit about how we'll handle questions and answers today. At any time during the presentations, you can submit a question online by typing it into the Chat with Presenter box on the left-hand side of your screen and clicking Send. When the formal presentations are completed, we will take questions from the Q&A and pose them to our presenters, who will then address them. For those who, if you have colleagues who weren't able to make it today, or you'd like to hear some pieces of this again, an archive of today's webinar will be available on getstrategy.com, which is Strategy Solutions website, as well as healthycommunities.org, ACHI's website. With that, I would like to... We have a dog who is joining us as well. And with that, I'd like to introduce our panel of presenters for this afternoon. We have Deborah Thompson, who is the President of Strategy Solutions, Ronald Ott, the Senior Vice President of Community and Government Relations at Excella Health System, Nancy Urich, the Manager of Community and Government Relations at Excella Health System, Charlene McClanahan, Director of Oncology Services at West Georgia Health, and Deborah Unger, Director of Community Benefit at Aurora Healthcare. And with that, I will turn it over to Debbie.
Okay, thank you. It is our pleasure to be here with you today. And during the course of this next about 60-minute webinar, we're going to be asking a number of questions. We have some polling features in here that we're going to be asking some questions to help you do a self-assessment to determine how well your hospital or system is to measure outcomes and impact.
The conference has been muted.
Measure outcomes and impact related to the triple aim as well as the return on investment. And we're going to be talking a little bit about how to think about integrating your strategic marketing, revenue generation, and population health improvement strategies together as part of your same approach. We found over the last few years that some people are really looking at community health needs assessment and implementation strategies kind of in a little bit in a vacuum, that there's a department over here that handles these aspects, and we're really not looking at how we're translating and moving toward population health. So we're going to be talking about that specifically. And we're hopefully going to be able to help you connect the dots a little bit and get excited about how our community health needs assessments and community benefit efforts can impact the communities we serve, as well as the hospital's bottom line, while we're still in fee-for-service mode. And the examples, the other speakers that we have today, and the examples that they'll be talking about are some of the cool things that we've come across in working with some of our clients in how they're doing and how they're maximizing their revenue, how they're really looking at integrating their community health with their marketing strategies, and how they're really working to measure impact in a broad way. So we're going to talk a little bit about strategies to improve the outcomes and impact as well, because we know a lot of organizations are struggling with that and really thinking about how they do that today. So our first polling question is this: which of the following best describes you? Press which dot relates to you as an individual. Are you a manager or director level staff? Are you an executive director or a CEO? Or are you a staff member working in community benefit? Or are you an other? Go ahead and vote. You should be able to vote on your screen. Okay, here's our group. About almost half of you are managers or director level staff. We have a few CEOs and some staff members and some that put themselves in the other category. A little bit about Strategy Solutions for those of you who are not familiar with us. Our company has a mission to create healthy communities, and we've been working with hospitals and healthcare systems for the last 15 years, but we've also spent a lot of time in the post-acute continuum of care, really looking at how the different sectors and communities can work together private sector wealth creating companies with community and government and social service. And we believe that healthy communities really understand and do interventions related to the social determinants of health, and that's the point of view that we bring into what we do. We also do quite a bit of planning and evaluation with organizations that we do by asking the questions, where are we now, where do we want to be, how are we going to get there, who must do what, and then how are we doing. And I want to start off by talking a little bit about the fact that we all recognize the letter of the IRS guidelines, and the letter of the law is we have to do these community health needs assessments every 3 years. But the spirit of the law, and I've been saying this for the last 3 or 4 years since the original draft guidelines came out in 2011, that the spirit of the law is really moving us toward population-based health planning and healthcare system delivery. And it's really about managing the health of a population to the triple aim. And as I look more and experience more and how I'm seeing things evolve through what Association for Community Health Improvement is doing and through what other people are doing, we really see that I believe that this spirit of the law is coming to pass, and that it's really about how do we move things in that direction. And we're going to talk a little, I said we're going to do a self-assessment and really think about how effective and integrated are your implementation strategies today. And I'm going to be asking you a series of questions as we go through the next series of slides. So my first question from the assessment perspective is, how effective do you feel that your hospital or health system has been overall in its efforts to impact the community through the implementation strategies that you're doing? Would you say that you're not sure, that you feel that they've not been effective, they've been somewhat effective, or they're very effective? Go ahead and vote. I enjoy seeing the responses of these as people vote as we're going through it. Okay, where's my results? There they are. Okay, look at this. Only 6% of you said very effective. We have 16% that said not sure or not effective. Oftentimes, when I do this in a group, when we can have some interaction around the answers, I'm hearing, well, I don't know if they're effective because I really have no way of measuring them. Or they're only somewhat effective because they're not necessarily connecting the dots. And we're going to talk a little bit about how your hospital or health system can start to think about that as we move forward. And here's something important to remember, that community health improvement strategies don't have to be community benefit. So for those of you who are limiting your intervention strategies to only community benefit, there's really nothing in the IRS guidelines that say they have to be community benefit. However, all community benefit strategies should somehow tie to the community needs. So you shouldn't be doing anything and calling it community benefit if it's really not somewhere in your, identified as a need in your needs assessment. But you really can think broadly about your community benefit and your community health improvement strategies. And I offer this, before we get to the question, I developed this hierarchy. I developed this pyramid. I actually created it based on kind of the approach of Maslow's hierarchy of needs, because as we've worked with health systems from various parts of the country, as well as those in various stages of evolution related to community health improvement, we actually see people that are doing community health assessments simply because they're compliance only. And we actually have a few clients that are simply doing them because they have to. We have others, especially those who have been doing these assessments for a long time, and many hospitals and health systems started doing community health needs assessments back when the hospital system that I grew up in did them in the 90s. Some of us have, tradition for community needs assessment back now 20 or 25 years. we started doing them collaboratively in our communities. And with the health department, like here in Northwest Pennsylvania, we started doing them in the early 90s when nobody knew what they were, and got involved with setting up public-private partnerships to do intervention strategies. And the model that we used here in Northwest Pennsylvania actually became the model for how the state now does its state health improvement planning districts. So some of us have been doing it for a long time, and are working on influencing public policy to create healthy communities, such as what's happening in Philadelphia, Pennsylvania. Healthy Philadelphia is working on a number of strategies, including they passed a cigarette tax in the city of Philadelphia of $2 per pack to help with the impacting of cigarette smoking. Not many communities have gotten so sophisticated that they're influencing public policy, but most of us are somewhere in between. We're either doing prevention and hospital-focused community benefit. There's lots of hospitals that are doing that. Some hospitals are doing programmatic interventions more broadly, sort of across the continuum to impact health status of a population. Many of us are working on collaborative interventions to impact the health status of the broader community, not just our patient population. Some folks are starting now to collaborate cross sectors to address root causes, which get into the social determinants of health, such as poverty and housing and those things that do impact health status. And we have some selected communities like Philadelphia that are organizing to influence public policy to create healthy communities in their cities or their regions. So my next question is, which of the following best describes your approach with your hospital or health system? Are you a compliance-only hospital? I'm actually expecting not too many of those. They're not hanging around. Those folks aren't hanging around ACHI. Are your hospitals focused on community benefit? Are you doing targeted interventions to improve health status across the continuum? And I would differentiate that. The targeted versus the collaborative or broad is, are you working in your community or just with your patient population? I know lots of hospitals that are working with their patient populations, but not with the broader community. Are you working collaboratively? Are you addressing those root causes, or are you doing anything really working on public policy? So go ahead and vote. And pick one, and some of you might be going, well, we're doing some of each, but I apologize that I only set it up to accept one answer, but you could be doing multiple ones because some intervention strategies could be collaborative and others are focused at your patient population. So I would encourage you to click on the button that is, sort of the higher order if you're doing anything, vote up rather than vote down. Okay, this is interesting. No one on the call is working at the public policy level, but a good 25% of you, which is really great, are working on collaborative and root cause things. Almost half are working on collaborative broad community projects. Some are working on targeted with their populations, and some are focused on hospital benefit. Excellent. So I included this information, and when we send out the slides, I'll actually send you a copy as part of the slide deck for those of you who registered, a copy of this Hilltop Institute issue brief, because as I talk about sort of forecasting where this is all evolving to, the Hilltop Institute is really sort of talking about how these things are evolving. And they're really encouraging states to take a leadership role on promoting regional collaboration, putting rules in at the state level to encourage community building, and to continue to support this payment reform. So my personal guess, is that we're going to not see a whole lot of compliance monitoring from the IRS, that more of it is going to come through the state level. And the Hilltop Institute is actually encouraging that, and I see that evolution happening around us. So for those of you who are in states that aren't doing a whole lot in terms of moving in that direction, this could be good news for now. But know that it's coming, and ultimately I think that will evolve this evaluation process similar to the way that HCAHPS have evolved from 20 years ago when we did not have patient satisfaction surveys or quality metrics when we didn't have dashboards. I think a lot of this is going to happen the same way. I know many of you may have seen the slide, the two columns of this, the pink and blue columns of this slide that AHA published back in 2011. But just recently, in June of 2015, a new second curve of the second curve has been added, which is the second curve of population health. So we're continuing to move in that direction. And I actually circled these two at the bottom because we really have to move in this direction as health systems if we're not there yet. We have to think about integrated, comprehensive healthcare information technology that supports this risk stratification and of the patients, as well as the outcomes and impact, and continue to evolve toward mature community partnerships that help us build on community-based solutions to address some of the social determinants of health. And I also talk about the strategies that impact care delivery in our health systems are often separate today. Many of us are integrating our needs assessment and our community benefit and prevention activities, but in some cases, our readmission and post-acute continuum of care strategies are out there in one field, and our service line development is in another place. And ultimately, we really need to be thinking about how these all come together, and how do we look at strategies that impact and improve community health. And here's one way that I like to look at it. I love this graphic here that I borrowed from Colonnade Healthcare, that I put the circles on it because our community benefit strategies often are geared toward healthy populations or the beginning of the at-risk populations. Our implementation strategies are often geared at the at-risk and those with chronic diseases that we're trying to manage them better or help improve outcomes by care management. And then we have our acute service line programs that are geared toward chronic and complex disease states, and really be thinking about it. And I put the green circle around all of it because as we think about population health and we think about our implementation strategies from our needs assessments, we have to be thinking about them in total. And we also have to think about how it impacts our image, how it impacts our bottom line, how we continue to sustain our healthcare systems as we go through this. Now, how much of a priority is it for your hospital or health system to measure the collective impact of system and or community-wide initiatives? Are you doing any collective impact measurements? Are you just struggling, the question is, are you just kind of struggling with what you're doing internally? Go ahead and vote. Okay, somewhat of a priority for collective impact. In some people aren't quite there yet. About a quarter of you are saying it's a high priority. How much of a priority is it for your hospital or system to measure the impact across the continuum of care? Is it a high priority, somewhat of a priority? And as you're waiting to vote, I'll do a little commercial. I'm actually doing a pre-conference workshop for the March ACHI conference in Baltimore on measuring, actually automating your outcome and impact measures. And the subtitle of the program is called The IT Guy or Gal is Your Friend. And Charlene McClanahan from West Georgia Health is actually on the call today to talk a little bit about what they're doing with the cancer program at West Georgia Health and trying to automate some of those indicators, because a lot of people are struggling with it, and it's difficult to get your handle around. Okay, about again, a quarter of you have it a high priority. Some people have it somewhat of a priority. And what's really sad is that I was talking to some folks in a hospital system just a couple of days ago about it's really difficult to get the attention of the IT department to even think about this. And it's a challenge. It's a challenge sometimes to do it. Now, how important is it for your hospital or system to promote your community health improvement as part of your branding strategy or what we're known for? Are you really are you really making it a priority to really think about how to brand this together? Deborah Unger from Aurora Health is on the call today to talk about their experience a little bit, because they've done what I consider to be a brilliant job in pulling that together and really making their community benefit activities part of what they're known for. But not everybody does it. And some hospitals that we are finding out, especially ones that are doing well financially or depending on what their relationship with their local municipalities are, if we don't figure out how to do it to some degree, we may end up getting challenged in a tax case, but particularly if we're not measuring all of our community benefits in the way we could or should and telling that story to the community in a meaningful way. So here's, again, it's a little bit more of a priority to some people that are on the call, and a little less in the somewhat important category. But I'll tell you what, back in the 90s, when the health system that I worked with was really promoting community health, we made it part of our branding strategy, and that leadership in community health and that leadership of caring for certain kinds of populations and certain initiatives that we took leadership roles in really actually helped us to drive market share to some degree, and really helped to drive people to really care about our programs. I borrowed this with permission from the Healthcare Advisory Board to share with our clients about thinking about expanding our services and expanding our thinking across the continuum. This slide was actually published by the Advisory Board Company in 2013. And most of our service line purview, and I know in some hospitals that we know, it's still very much acute care focused. Folks are starting to organize population health initiatives and trying to think cross-silo. But oftentimes our preventative care and our screenings, our community benefit stuff, is being tracked on an Excel spreadsheet in the community benefit department, and we have no way of really looking into the medical records to see where people are going. But we really ought to be promoting our system's expertise in coordinated care, maximizing the fee-for-service as long as possible, and preparing for bundled payments, because we have to be managing folks across the continuum and really thinking about how our information systems track people across that continuum. We also have, as we look at the traditional responsibilities of our service line administrators, it's moving to new responsibilities, as we could see by the bottom boxes here: change management, partnership building, patient satisfaction, the patient experience across the continuum. And I actually copied and pasted the green box from the second curve of population health here, because we also have to be thinking about that integrated technology and how we really keep track of patients and help them also access their records as well. And again, as we move up through the stages of system-level integration, we'll be looking at embracing shared operating standards and shared clinical information systems. But we also have to be, as we move forward in our evolution, we should and will be doing more with continuing disease management and continuing wellness intervention. And that should be part of what we're thinking about moving forward. And now I'm going to stop. I'm actually going to unmute our lines, so hopefully your individual lines are muted, so that I can transition over to some of our speakers.
The conference has been unmuted.
To allow them to talk a little bit about their experience in working on this. And I want to talk a little bit about, first, to queue up the Ron Ott and Nancy Urick from Excella Health to talk about employee wellness as an intervention strategy. We see a number of our clients that are doing needs assessment picking employee wellness as an intervention strategy because our hospitals and our health systems are often the largest employers in our county. They're a captive audience. We can influence them if we want to, although many have not embraced or implemented the strategy because sometimes there's lawyers talking, we can't legislate behavior. But Excella has done not only what I consider to be a really good job of doing the intervention strategy with their employed population, they are also using the strategy as they're using it as an occupational health strategy to get other employers in the community on board and utilizing their health system for the testing and the patient management. So with that, I'm going to turn it over to Ron Ott and to Nancy Yorick to talk a little bit about their approach and some of the results that they've had.
Thank you, Debbie. Can you hear me?
Yes.
Yes.
Okay, great. I do want to start out just for a moment to thank Debbie and Strategy Solutions for their help and support in doing our community health needs assessment. As Debbie mentioned, we were involved in this process beforehand, but with new IRS guidelines, there were a lot of compliance issues that you needed to fulfill in addition to doing the right thing for the assessment. And Debbie and her team really were very helpful in helping us go through the process, create the steering committee, do our priority setting, and then actually develop an implementation strategy and plan that we think and we hope is making a difference. So, Deb, thank you for that. This has been a journey for us. If we look at the employee health aspect, I guess we really began to focus on it very seriously about 7 years ago when we saw our increases in the 27% range in terms of our costs. And we knew we needed to do something to engage our employees in taking more of a personal interest in their health. We started out by, I guess, using the carrot, saying that we would give you $150 if you completed the wellness program that we had established at that time. And we had a whopping 2% of our population participate in it. So the next year we said, if you don't, it's going to cost you $15 a pay. And we had about 85 to 90% participation in the program. And that really started the basis for us, I guess, hate to say it, using a stick kind of model, but one that goes along with a lot of other carrots and support for our employees. And I think it's been a journey for them, too, in terms of understanding the value to them of really participating in this program. If you look at the first slide there, we describe our program. And the base program is really an 80-20 health insurance plan with a $2,000 deductible. So pretty severe from a stick standpoint. But they can participate in the program that provides 100% coverage, home host with Excella Health, if they participate and complete the wellness program that we've established, both they and their covered spouse. And with Nancy Yorick and her team with the Wellbeing Center through HR, we provide a tremendous a lot of support throughout the year in making it easy for them to meet these requirements and really look at ways to improve their own health and wellness. So that is the base plan, and they have an opportunity, as I said, to have the coverage if they participate in it, along with the $15 per pay. Again, if they don't participate in the plan, they have to pay that as well, too, along with their spouse. And again, that's probably not as big a stick as the other, but it still does make a difference. And the advantage to that is for the 7% of the population that don't participate, we were pleased to get up to 93% in this past year. $15 per pay for that 7% helps us to fund our other wellness programs and initiatives. So it really is a win-win from that standpoint. I want to turn it over to Nancy to do the next slide to talk a little bit more about the work that they do in supporting this initiative and the positive benefits to the employee for participation. Nancy?
Good afternoon. So the Wellbeing Center is a department of Excella Health. We have a 10-person staff, and we are the ones that are providing all of the wellness services for our employees and spouses. Our program is based on accumulating 200 points to complete the program. So there are 3 requirements for that program. They must do the health risk assessment as well as the True Age questionnaire on our wellness platform, and then they must attend one of our biometric screenings, which is also done by our staff. We do ask that they have a PCP to send the results to. Our screening application will electronically fax those results to their physician within an hour of the screening. So we really feel like we're closing the loop there, because if there are concerns at that screening, if the employee doesn't address them, then they're receiving a call from their physician's office to come in to be evaluated. And then we have a number of ways that they can accumulate the rest of their 200 points. And one thing that we do focus on are our preventative screenings. We give 40 points for a colonoscopy, 25 points for a mammogram. So our screening rates have been very high, and that is translated into diminishing high-cost claims for late-stage cancers, especially breast cancer and colon cancer, which then translates into a cost savings for the organization. We also provide a lot of carrots. We have 4 on-site gyms. We charge our employees $5 a pay to belong to that. They can access them 24/7. We have 1 in each of our 3 hospitals and 1 at our largest outpatient center. Overweight and obesity is also an issue in our organization, as it is nationally. So we are in our 4th year of our Just Lose It contest, where we tell them, we just want you to lose weight. We don't give you a specific way to do that. One size doesn't fit all. So what we do is have them sign up for the program. My staff goes out to all of our sites quarterly and does a weigh-in. So the person that loses the highest percentage of body weight for each quarter receives a $500 cash prize. And then at the end of the year, we have a very nice program where we invite the finalists. We announce the winner there, and they are given a cash prize of $2,500. And then we also give cash prizes to our 3 runner-ups. We also have a web-based pedometer program called Walking Spree. We give the employee and spouse a $25 credit to purchase the pedometer of their choice. And then we set a step challenge for the year. This year we're going to 10,000 steps a day. So the employee pays the annual subscription fee, but at the end of the year, if they have met our step challenge, then we refund them that subscription fee. We have monthly drawings, cash drawings, that increases monthly as we go through the year for people meeting the challenge. And at the end of the year, we sort of do a prize patrol where we get balloons and a giant check, and we surprise the winner of the contest with a $1,500 check. We provide free on-site health education programs. We have a certified tobacco cessation specialist on our staff, and she can do tobacco cessation counseling and nicotine replacement therapy for those people interested. We also want to keep our employees healthy and reward them for improving their health. So when we do our biometric screening, we use an iPad screening application called My BioCheck, and it provides their results in the form of a report card, because everyone can relate to a report card. So if they get B+ or better on their report card, or if they have achieved a full grade improvement, then we award them with 100 points towards their wellness program completion. Our biometric screening application will also red flag those people who have metabolic syndrome. We know they're at much higher risk for developing diabetes and/or heart disease. So when we identify those people with the screenings, we do offer them free health coaching. We have both individual and group health coaching available. Our dietitians can provide free nutrition counseling to our employees and to all of their family members. And we also offer additional points for not using tobacco. And I will turn this back over to Ron.
Okay. Thank you, Nancy. And to close it out on the next slides, I know everyone is results-oriented, and we've listed a couple of the things that we've been fortunate enough to get some nice recognition for as top 100 healthiest employer, and also the Pittsburgh Business Times healthiest employer. But we recognize that it really is a journey, and we see we still have tremendous opportunities with our own employees, and Nancy and her team do a great job with that. In terms of the AAA, we went from a 27% increase back in 2008 to a 3% reduction in premiums for 2011, and we still continue to see improvement there, saving $5 million over that time period. Felt comfortable enough to be able to go self-insured for the past couple of years and see additional savings that way. We've added the occupational health activities, and to Debbie's point, in terms of a marketing strategy, and I've really reached out to probably more than 24 employers in the area now that are looking to find ways to partner with us to improve the health of their employees as well too. Clearly part of our community health needs assessment, but goes well beyond that in terms of trying to improve population health. So we're making nice progress, but we still have a ways to go, and nice recognition from the Hospital Association of Pennsylvania too. So we will keep it going. Debbie, thank you for the opportunity to share.
Okay, thank you, Ron and Nancy. And I'm now going to turn it over to Deborah Unger to talk a little from Aurora Healthcare in Milwaukee, Wisconsin, to talk a little bit about their Better Together Fund and some of the things that they're doing to promote population health, to intervene to make a healthier community, and make it part of their branding strategy.
Thanks, Debbie. Well, next slide, please. Aurora was founded in 1987 with 2 hospitals in Milwaukee County, and has become, over the course of the years since then, the largest private not-for-profit integrated healthcare provider in the state. We're in over 30 counties and 90 communities with 15 hospitals, 150 clinics, 70 pharmacies, and 30,000 caregivers, including our employed physicians. If you can picture the state of Wisconsin, we're primarily on what we like to call the east coast of Wisconsin. We also have the largest home care organization in Wisconsin, and we've also been in the forefront of doing community health needs assessments dating back to 2003 and even older. And I've included our website in case anyone would like to visit it and take a look at some of our community health research. Next slide. Having been founded almost 30 years ago in Milwaukee County, where the disparities are the greatest, it really should be no surprise that our most evolved community benefit programs are here in Milwaukee County. Looking at the community health needs that we've been tracking over the last 10, 15 years, these fall in the area of clinical care, social services, and what we call abuse response services. In short, our clinical care programs include Aurora Walker's Point Community Clinic, which is the largest freestanding community clinic in the state. And the staff of that clinic also hold a clinic every week at the Salvation Army Shelter in Milwaukee and treat patients there. We also have a Bread of Healing clinic, and together these services cover the geographic areas in Milwaukee County where the populations are the most diverse and underserved. Our social services program through Aurora Family Service is also in a freestanding facility in the heart of the city, community-based. There's a staff of 120, and they provide numerous specialized programs in the community, as well as staff who work in our Milwaukee County hospitals. And in particular, they are positioned in our EDs and our NICUs. Lastly, these abuse response services consist of our Sexual Assault Treatment Center, which we believe is the oldest and largest such center in the state, and our Sexual Assault Nurse Examiner program, which is provided in all but 3 of our 15 hospitals. Included in that is a program called Safe Mom, Safe Baby, led by a SANE practitioner. And this is for pregnant women who are experiencing intimate partner violence. And last but not least, we have a program called the Healing Center, which again is freestanding and off-site, but this is where people who are treated in our programs can go to get alternative and holistic modalities as they are on the path to healing. So together you can see we are serving many, many people in these programs. What became apparent in our first 3 years of completing all the 501R requirements is that importance of working with community partners to expand the continuum of care. And in 2014, we had a pretty good year, and our leadership and our board of directors approved us to establish what we call the Better Together Fund. It was a one-time discretionary fund that we housed in the Greater Milwaukee Foundation, and they helped us put out requests for proposals from our partners, some that we work with and some that we were hoping would apply, to help expand behavioral health services in the free clinics and FQHCs in our markets, and also abuse response services. And as you can see from this slide, we had 21 recipients receive a total of $6.6 million to expand behavioral health services in the community clinic setting, and another $3.4 million was given to social service agencies, colleges, and universities to expand education and prevention services for sexual assault and domestic violence. So the upside of doing this Better Together Fund programming and the process that accompanied it was it brought all these wonderful things we're doing to the attention of our marketing team. And they reached out then and worked together to produce a couple of TV spots to communicate and share our message with not only external partners, donors, and stakeholders, but also our own 30,000 caregivers who have had the opportunity to see these spots when they've been watching the Green Bay Packers playing football on Sunday afternoons. So, Debbie, I guess you're ready to show the spots.
Oh my God.
Life prevails in things we cannot see.
Oh, crazy.
Compassion.
Super crazy stuff. Yeah.
Dignity. Love. Invisible threads connect
Yeah.
together.
In fact, I probably have the second one because I got mine donated.
We are human.
Ended up leaving, but
We're human.
yeah.
And in the good. And the bad.
No money.
No.
Dear Mark, I'm writing you today, and I am almost 2 years sober.
This has been a long road trying to start over.
You're an amazing little girl. You found the courage inside you somehow to get help.
Not knowing where you're going to end up the next night.
You survived for a reason. I'm trying to find purpose in life now.
Always be married and a dream.
This is what I have learned.
We can make it to the other side.
Give that blank back to your purpose.
You don't have to do it alone.
I want you to walk with your head held high.
You have a beautiful
Luke Skywalker appears to be breathing in the phone. We can't hear.
Making communities healthier in ways stronger than medicine. Aurora Healthcare for your life.
Do you want to say any sort of closing comments about those?
Well, they've been very well received by everyone that we know, and they've been a real boost to us in the Community Benefits Department to see our good work represented so compassionately.
Okay, good. And it's just a great testimony. It's just a great testimony to showing how the Aurora Healthcare is actually branding their community benefit and their community health improvement activities with their health system. So back to some questions. Do you have a mechanism to track and report the outcomes and impact of your implementation strategies beyond the number of people? Go ahead and vote. Okay, most of us have some. You know, my favorite butt of that is, yeah, it's in an Excel spreadsheet. Here is the data Automator, not in an Excel spreadsheet, okay? This is my next question.
Does that mean like utilizing Sabisa?
If you're using Sabisa for tracking outcomes, not just counting the number of people that are participating and the cost associated with the community benefit, which is what most people are using Sabisa for. They have some new modules. Sabisa has some new modules that include the outcome measures. But most people are using Sabisa. So I'm talking about the outcomes part of it if you are using Sabisa. So this is interesting. Where did my poll go? Here's my poll. Some people are working on it. Most people aren't. We got a lot of non-automated data collection going on. So, you know, how do you begin to improve your impact measurement capability? Okay. And first of all, you think about developing logic models, look at the outcome and impact measures to it, talk to IT professionals about creating data collection and reporting systems through electronic applications and software, and actually work on engineering those things into the electronic medical records. And we have with us Charlene McClanahan from West Georgia Health to talk a little bit about what West Georgia Health is doing to really automate the indicators and actually make the care delivery process, starting from outreach and screening all the way through the management of the cancer patient through the navigation process, part of their process at West Georgia Health. So, and then you document the development strategies as part of your action plan. So I'm going to turn it over to Charlene and let her talk a little bit about what West Georgia Health is doing for cancer care.
Thank you, Debbie. Yes, and I too want to say a big thank you to Debbie and Kathy, and those happen to be just two of the ones I've worked with from Strategy Solutions that have helped us tremendously with our community health needs assessment and just pulling all of this information together, as Debbie has mentioned. Of course, granted, I am only a segment of the entire program in that I am the Director of Oncology here at West Georgia, but I'm speaking to that because that's obviously near and dear to my heart. And one of the things that we have always felt that in the oncology program, which is probably true of many of the programs out there that have an oncology program, you do feel that you do a good bit for community benefit for the community because you're out trying to do screenings and health fairs and things because you want to bring your population in at the earliest moment that you can to make a difference in their lives and in the outcomes. And we've been doing a number of wonderful programming, and I think, again, as someone mentioned earlier, maybe not to the forefront of all the hospital and all the marketing department, but when you begin to sit down together and realize what all is going on, it does become quite an effective tool that you're doing, but you have no way of making that a piece of the whole picture. And that's sort of where we were in this logic model that we started. So one of the main things that we did when we began to talk about this, at the same time that the IRS decided they wanted us to come up with a community health needs assessment document as such, the Commission on Cancer, as you all know, came up with Standard 3.1, and it was their standard on patient navigation, where they felt that they wanted you to use a community needs assessment. Same type thing, everybody getting their piece of population health, of community health, of getting out there to get people together with chronic diseases that you could find out initially how could you get them from screening to the navigating of the process to being treated, to from treatment to, well, how are you affecting lives? And the hospital bottom line. I mean, are you getting the patients in? Are you getting them screened? Are you affecting the outcome of you have found a cancer at an earlier stage? What has that done for the patient first and foremost? And then what has that done to be able to get more patients in to have this same type process done? So this is sort of where we were in using this logic model. We got a group of people together, and in our group, we began to think of all the people that could be a part of this. Like our IT department was a perfect example. Our patient access department was another example. Marketing. And we put all these people in a room and discussed, okay, here's what we are doing in our community outreach. Here are the health fairs we're going to. Here are our barriers. Here are our problems. What can you do to help us identify these particular issues that we need to find out and to implement them so that we can show that we're making a difference, that we have some outcomes, some actual numbers of people that are coming into our screening, that we're doing clinical breast exams, that we're giving vouchers, that we're being able to. And one of the things that we identified is we do not have a portable mammography unit on our van that goes out. So what could we do that would make this a very streamlined process? And again, this is where our IT department came into play to say, well, we can immediately get you a notebook or that you can carry out, a phone with a hotspot, and no matter where you are, we can connect so that you can connect into your registration venue here at the hospital, which is what we did at the next fairs that we went to, and we're able to schedule those women right there. And it was not a matter of actually having to give the voucher, make sure the woman gets to us, but we could actually start the scheduling and discuss that as a barrier, and we effectively took care of the barrier using our IT department. And since that time, they have very much become an advocate for our service line and have worked very well with us to make sure that we are able to have these indicators that we're using out of the navigation software that our navigators are using to come up with these distinct issues that we need to see, and they can help us identify them and pool them to our outcome data, which is what we actually want to see, that we are affecting the health of the population. And of course, as our long-term game, that we're getting our cancers at an earlier stage, and that we're giving these patients then some type of survivorship plan to use to go forward from that. So it's sort of like a complete continuum now that we've been able to engage, if you will, the other departments of the hospital into our service line. And I think we are working on doing this throughout the other service lines of the hospital. But it has definitely made a difference for us. And then, of course, the standard, as you're all sitting there, if you know anything about the Oncology Commission on Cancer standard, you must make this part of your cancer committee. They have to be a part of what are our barriers, what are the things that we need to impact, and what are we going to choose for the coming year to use to work toward for our navigation process, and to see that we've actually affected or impacted our population. And at this point right now, we are at the end of our first 3 years, so we are going to be we're in the process of doing our evaluation that at our December Cancer Committee meeting we will do. And we're doing this by our navigators are giving evaluation, we're doing sort of interviews with set numbers of patients, and I'm going to be interviewing clinicians. We're going to put all this data together and show our cancer committee or share with our cancer committee our evaluation process of what we found our barriers really are, and then choose from that with their input what we want to work toward next year. So by doing this model, it has definitely helped us integrate, if you will, our service line into the entire community health needs assessment and vice versa.
And really start to automate the indicators. And what Charlene was talking about, you know, they're actually doing the evaluation of those programs. These are the elements that are in that evaluation. And the next couple of slides here talks about, you know, how Charlene do is she started that process to get the IT people involved. You know, start at the top. Get the blessing of the most senior administrator to put the right IT professionals on your team. So Charlene was able to get the right IT professionals who were knowledgeable about the various softwares. And in her situation, there were 3 different softwares that the nurse navigators and the clinicians actually deal with across the continuum of care. And then look at, you know, how are they being constructed? Where are the variables that need to be tracked? And then determine what they are so that they can be captured. And one of the things that we're talking about doing in terms of the next generation of this evolution, which was a conversation that is a part of sort of the next steps of the needs assessment, is trying to teach, there are actually lean specialists at West Georgia Health, so we're proposing that we teach the lean specialists who understand work process flow how to do logic models so that they can help bring this outcomes thinking to their work in trying to improve work process so that they can help what I call bridge the Tower of Babel problem, because the IT people speak in database language and the clinical people speak in clinical language, and many of them are nurses or respiratory therapists or other clinicians that really don't care about a variable and whether or not it's in a field. So, but we try to bridge that problem so that we can create reports from the data. And the next few slides, you'll be able to see these better when we send you the documents from this webinar. But we actually have some reports that were created by an informatics expert at St. Vincent's Health Center on diabetes management that pull data from 4 or 5 different sources to give the physicians every day when their patients come in, the doctor gets a dashboard on what's going on with the patients and what's going on over time. So we hope that, you know, through looking at these 3 examples, we are helping that you're better able to determine your service line development and program marketing strategies that are related to community benefit and some of your at-risk interventions, and think about how your patients flow through your continuum of care so that you can maximize that fee-for-service revenue, look for care enhancement and cost reduction opportunities, but also think about what are those outcome and impact measures so that you can not only evaluate, but you can actually quantify and automate the indicators for your outcomes. And we encourage you to talk to your IT professionals about how that data can be collected and reported, and develop an action plan to collect and automate the data reporting itself, and to have that action plan be part of your implementation strategy for your needs assessment. Because if you do all of those things together, your healthcare system can benefit from the marketing and advancement, can benefit from the increased revenue associated with people knowing what leaders you are in community health, and you can then begin to automate and show the outcomes of what you're doing. So that you can actually see that impact through your evaluation efforts. And with that, we're finished. So I'll open it up to the floor. Are there any questions? Are there any questions from the participants that you would like to throw in verbally before to the questions that were sent in via the chat? Anyone want to venture a question or two? Okay, well, you keep thinking about it. I have a question here from a participant that asks, how do we get started with the outcomes and get our IT department involved if they're not used to doing it? So I guess the answer to that question is, our advice is start at the top. Have a conversation with the Chief Information Officer at your organization about who's best equipped to help support this. What I've found in working with various hospitals is that there's actually quite a bit of activity going on in most IT departments to either thinking about healthcare information exchange or actively working on supporting population health. The problem is that often the folks that are working on the implementation strategies just aren't connected to that thinking, and the IT professionals themselves don't have a sense of what a day in the life of is like. One of the things that Charlene didn't mention in her remarks was that Karen, the IT guru that was the most knowledgeable about systems in her hospital, actually shadowed Wanda, the nurse navigator, while she was doing screenings to really look at what her process flow was and to how to automate those indicators, which ended up being very helpful to that whole process. Other questions?
Hi, Debbie. My name's Jenny Mormon, and I work for Fairview Health Services in Minnesota. And I have a question around, do you have any suggestions for bridging the gap of not completely compliance-based thinking, but definitely not thinking that is integrative and kind of that second curve thinking about how you write an implementation strategy that ties to the organizational strategies if you've traditionally done very just community-focused work?
Okay. Well, I guess, how do you bridge that gap? First of all, one of the things that I suggest, and because we don't connect things well internally, what kind of education programs are your executive leadership going to? Bless you, whoever's on the phone. And the reason why I say that is because I've noticed, you see me integrate slides from the American Hospital Association and the advisory board company into my presentation. What I found is there are a lot of hospitals are members of the advisory board company, but they're not using, it's like, okay, we go to their programs and we look at what we're doing strategically, but they're not looking at what are the activities that we're doing in our hospital or health system that fits into this. So we can bridge the gap by intentionally finding out what are the things in our strategic plan, what are our C-suite executives learning about and thinking about, and then the community benefit professionals can say, hey, listen, this is an example of this. We're already doing these 15 activities on the front end of the cancer service line. We're doing these 4 activities on the front end of the cardiopulmonary service line. And begin to connect the dots for people, because I find that is people that we're not doing that well. We're not looking at our strategic plan and saying, here's what we're trying to build strategically, and here's how our community health improvement efforts that we're about connect in there. The second thing I suggest, and Aurora Health is very good at this, but not everybody does this, because I've met a group of people that are what I'll call minimalists on the intervention strategy, in that, I only want to pick 1 or 2 intervention strategies or implementation strategies because then I'm on the hook with the IRS. Well, I say, you ought to do an inventory in your hospital of the things that you're already doing related to community health, prevention, and or community benefit, and actually find out what they are. Because my experience is that many people underreport their community benefit. They also underreport and underconnect those outreach and screening activities with the service lines. because the community benefit department is doing them or the community wellness department is doing them, we don't think about how they strategically connect to one another and actually sit down and have a conversation about how they fit. So in other words, when we do implementation strategies with folks, we're actually doing an inventory. We'll actually sit down with all the clinical managers and saying, what kind of outreach activities are you doing? What kind of screening are you doing? Are you counting these as community benefit? You missed this. Are your nurses doing research? How does that fit? What outcomes are you measuring? So we're asking that series of questions to kind of do the audit for the implementation strategies. And then we're at the end of it, when it comes time to actually develop those implementation strategies, say strategically, what do we want to accomplish in our community? What do we want to be known for? Do we want to be known for a hospital that does these certain kinds of things? Do we want to be known as the heart hospital? Do we want to be known as the hospital that really takes care of these kinds of conditions? And if that's the case, it's like live into the mission that you say you want to be and make sure that your activities are fitting in there, and then set a goal to say this is what we want to accomplish, and then try to fit your tactics underneath it. And then design new tactics, including the broader community work, and that will help you, again, connect the dots. I know that was a long explanation, but I hope it helps kind of say, look at where you're at, assess it, see what you're already doing, and then try to say, well, what's the strategy really, and how do these connect? And that may mean educating your leadership about how they connect, because they may be missing it.
That was an awesome answer. Thank you.
You're welcome.
I really appreciate it.
You're welcome. Other questions?
Hey, Debbie, this is Ron. I just want one additional comment, which maybe brings in the data analysis, outcomes, and then maybe eventually using that for marketing or branding. In this next phase of our Community Health Needs Assessment, as you know, we're going to be partnering with the Healthy Communities Institute as well, which helps us to identify data on a much more location and zip code basis, but also helps us not only look at the data and identify it, but track it and measure it and look at some best practices, and then eventually embed that into our websites and use it as a marketing and an educational tool to the community in terms of what programs we're doing and how it's eventually improving the health status of the community. So we're pretty excited about that next phase, but I think it brings in some of the key points that you've made today.
Mm-hmm. Thank you for sharing that. Other questions? To think about any other questions you might have. I do want to mention that I don't believe that you can click on the link right from this webinar to be able to get to the webinar evaluation. This link will actually be in the email that is sent out from my office with the webinar slides and the materials. We'll be sending this link out with it, so please make sure that you take a few minutes to give us feedback on the presentation. It's actually wonderful feedback for us as presenters. It's great information for the Association for Community Health Improvement, and if there's any other topics that you're interested in, we want to know. Your feedback helps us improve what we're doing. And then the final commercial. Julia, you want to do a commercial for the...
Absolutely. And Debbie and everybody else on our panel, I want to thank you for a really excellent webinar. I hope that this was incredibly useful for all of our listeners. And as Debbie said, now comes a little bit of self-promotion. So we, as you can see here, ACHI hosts an annual conference every year. This year it will be March 1st through 3rd, 2016 in Baltimore, Maryland. And you can come to hear more presentations like the one you heard this afternoon and many, many more. This year's conference theme is From Healthcare to Healthy Communities. And every year we bring together over 500 community health stakeholders from the healthcare, public health, and community development sectors who are all deeply invested in improving the health of their communities. This year's meeting will include 4 pre-conference workshops, one by Ms. Deborah Thompson herself, 3 plenary sessions, 2 site visits of community health improvement initiatives in Baltimore, and 6 topic tracks. So for more information about the conference and to register, you can go to healthycommunities.org/2016 ACHI, and you should know that the early bird rates are available until December 31st at midnight. And with that, if you all don't have anything else to add, I thank you and hope that you enjoy the rest of your afternoon.
And I will stay on the line for a few minutes if anyone has any additional questions.